So my topic for the day is GLP-1 receptor agonists beyond glycemic targets, or what are the extra glycemic benefits that these agents offer. This is a very familiar slide. All international guidelines, they recommend the use of GLP-1 receptor agonists in type 2 diabetes with background ASCVD. But this is just the tip of the iceberg, because the efficiency of GLP-1 receptor agonists as anti-diabetic agents is just the tip of the iceberg, because they have enormous potential in improving disease processes affecting almost all the organ system of the human body. So this case report we had published in 2020, we were actually seeing a middle-aged type 2 diabetic with plaque psoriasis. He was already on other anti-diabetic medications, and when we started liraglutide for this patient, within a span of 4 weeks, we could see substantial improvement in the plaque psoriasis. So lesion was resolving. And this occurred even before the glycemic control was achieved. So definitely, these agents were, in a way, immunomodulating. So there were also other mechanisms of action of these drugs. So we all know that GLP secretion is through different surfaces, like the neurons in the nucleus tractus solitarius, L cells of the gut in the distal jejunum, ileum and colon, and also the alpha cells of the islet. So they have profound effect, and they are expressed in different organ systems, as you can see in the slide. So it's a single molecule, but because of the multiple mechanisms, it has effects on different disease processes like diabetes, cardiovascular disease, obesity, non-alcoholic steatohepatitis, CKD, Alzheimer's, and arthritis. So we will be looking, in short about these conditions. Firstly, we look at GLP-1 receptor agonists and healthy heart. We all know that diabetes is atherosclerotic continuum. So 85% of all CV deaths, are caused by atherosclerosis or ASCVD. And life expectancy is reduced by 12 years in patients or people with diabetes with pre-existing ASCVD. So these GLP-1 receptor agonists, they target multiple pathophysiological defects of type 2 diabetes by modifying various metabolic risk factors, and their effects are far-reaching. So they affect almost all the organ systems, as you can see in the slide. Particularly, we will be looking at the SOUL trial, which is oral semaglutide cardiovascular outcome trial, wherein 3, 7 and 14 mg oral sema was compared with placebo. The primary endpoint was to demonstrate that oral sema lowers the risk of 3-point MACE versus placebo, and the secondary endpoint was to compare incidence of CKD, CV events, peripheral arterial disease, glycemic control, body weight, and safety. There were additional 2 exploratory endpoints like cognitive function and smoking. If you look at the results, the SOUL showed 14% reduction in the risk of MACE, including CV death, non-fatal MI, and stroke. And oral sema appeared to be safe and well tolerated, as in previous trials. This slide pertains to the data from Pioneer 6 trial, and it establishes the CV safety of oral sema. So the potential mechanisms of cardioprotective effect with GLP-1 receptor agonists, on one hand, it is brought about by the improvement in blood flow, improving the plaque stability, increasing vasodilation, improving the endothelial function, and also at the level of the kidney, increasing natriuresis and diuresis. And on the other hand, it decreases inflammation, decrease smooth muscle proliferation, and decrease platelet aggregation. So by this, it confers 51% reduction on all-cause cardiovascular mortality. Coming to obesity, we all know that GLP-1 receptor acts centrally, bring about satiety. They act at the arcuate nucleus in the hypothalamus, stimulating the pro-opiomelanocortin, and at the same time inhibiting the neuropeptide Y, bringing about satiety. In clinical practice, treating obesity is a challenge, because as you can see, if a doctor, informs a patient that you have metabolic syndrome and you need to lose weight, the patient is like, how to lose the weight by 50%. So they have unrealistic expectations. But if you look at the data, this data is from look ahead. Just a loss of 5% body weight reduces 48% lower hazard of CVD at the end of 10 years. The same way, a 10% weight loss in type 2 diabetes and obesity brings about 21% lower risk of composite outcome within a year. So 5 to 10% weight loss also would go a long way in preventing cardiovascular complications. And if you see new diabetes busters, that is single agonists, we already have semaglutide giving about 8% weight loss. We also have dual agonists like tirzepatide, which is a GLP-1 receptor plus a GIP receptor dual agonist. It promises to give 15% weight loss. Going further, we have the triple agonist, retatrutide, which is GLP-1, GIP, and glucagon receptor agonist, and it can give a whopping 20% weight loss. So definitely, it's only improving, and it's no surprise that by the end of 2022, the sales hit $25 billion globally. And we also have orforglipron and danuglipron, which are the new oral GLP-1 receptor agonists in the pipeline. In Alzheimer's also, GLP-1 receptor agonists can bring positive changes and delay the disease process by decreasing neuroinflammation, increasing the cerebral glucose metabolism, improving the blood-brain barrier integrity, increasing the synapse viability, and decreasing the amyloid deposition. Same way in arthritis also, GLP-1 receptors, they have the potential to slow the disease process. For example, in fibroblasts like RA synovitis, the administration of lixisenatide, which is a short-acting GLP-1 receptor agonist, it resulted in reduction in the inflammatory response. This was achieved by decreasing the expression of pro-inflammatory cytokines such as TNF, interleukin 6, and 8. In the same way, GLP-1 receptor agonists have been shown to increase the exercise endurance. The studies indicate that acute exercise and short-term endurance training significantly increases GLP secretion at 30 and 45 minutes after exercise. If you look at the kidney parameters also, GLP-1 receptor agonists, they confer nephroprotective outcomes, both indirect and directly. And specifically semaglutide, this data is from the post-hoc analysis of SUSTAIN 6 and PIONEER 6 trials, and semaglutides were able to reduce the annual regression of eGFR. Similarly, the FLOW trial, this was subcutaneous sema compared with placebo, and it has also shown 24% lower risk of composite primary outcome, and also slowing down the eGFR decline annually by 1.16 ml, and 18% lower risk of CV death, non-fatal MI, and non-fatal stroke. In cases of muscle, formerly known as NFLD, also GLP-1 receptor are promising, because most of the metabolic syndrome patients, more than 50%, they have metabolic dysfunction associated steatotic liver disease, and there are currently no US FDA approval is there for any pharmacotherapy. These four are considered: pioglitazone, vitamin E, GLP-1 receptor agonists, and SGLT2 inhibitors. As you can see from the slide, majority of the international organizations, they consider GLP-1 receptor agonists in NASH. By the end of this year, I think daroglitazone is going to get the US FDA approval for NASH treatment. So this trial is, Essence is a phase 3 trial wherein once weekly sema was compared with placebo, and then the primary objective was to see the improvement in liver histology and lowering the risk of liver-related clinical events. And definitely sema has shown benefits. In the same way, the ASSAULT 2023 practice guidelines also recommend the use of semaglutide and pioglitazone in NASH patients. And compared to other anti-hyperglycemic drugs, GLP-1 receptor agonists definitely have benefits across all liver parameters. So to conclude, the future of GLP-1 receptor therapy is promising with more efficient formulations, and with increasing clinical evidence, GLP-1 receptor agonists are set to become essential in treating complex and chronic diseases. I thank one and all for the patient hearing. Thank you, Ahmedabad.